Well, good evening, everyone, and welcome to Navigating the 1099 CRNA Landscape in 2026. I'm Sharon Pierce, not what you see on the screen. I'm not Jeremy Stanley, um, but I used his Zoom link to get in. But again, I am Sharon Pierce. And I'm excited to host tonight's webinar alongside Jeremy as we bring together experts in the 1099 CRNA space. Tonight's conversation will be focused on 1099 CRNA practice, the opportunities, the realities, and the decisions that will matter most to you in 2026. Whether you're currently working as a 1099 CRNA or considering the transition, our goal is to give you practical insight that you can use immediately. We'll begin with the 2026 market reset, where we will discuss why this is a pivotal year for 1099 CRNAs, what's shifted since 2025, what remains structurally strong, and how to think strategically about income, risk, flexibility in a maturing 1099 market. Next, we'll look at the national workforce with Nick Blank, focusing on the broader forces shaping CRNA demand and how they influence opportunities for 1099 CRNAs. We'll then move into the facility level reality of 1099 work with Tracy Young, who will talk about compensation trends, something everybody is always interested in, hiring priorities, and what CRNAs should know when evaluating 1099 opportunities. After that, we'll turn to one of the most important aspects of being a 1099 CRNA, contracts. We have John Apino from Contracts Diagnostics, and he'll walk us through key provisions that you must understand. We'll talk about non-compete trends, negotiation strategies. From there, we'll shift into something we all love to talk about, taxes. And we'll talk about financial planning for 1099 CRNAs, where Jeremy Stanley will discuss the Permanent Tax Cuts and Jobs Act landscape and S Corp considerations, tax strategy, retirement planning, which I look at more and more each day, and financial considerations unique to high earners. We'll then hear from Brian Doyle of AANA Insurance Services, who will provide us an update on the malpractice and insurance market for 1099 CRNAs. We'll close with a live Q&A if I do my job well and keep these brilliant men within their time allotment. And you will hear some key takeaways, and through the chat, you'll be able to ask some questions. So, with that, Jeremy, you ready to start?
I think you did a great job. And, this is our second annual 1099 update that we started through the 1099 Institute. And working with AANA, we've been able to help a lot of CRNAs transition to 1099 and hopefully make their 1099 endeavors a little stronger and a little more education on what it takes to run a 1099 business. So, Nick, man, you're in the hot seat here. I really appreciate Nick being here with us this year. He wasn't with us last year, but now that we've got him roped in, he might be return each year. So, Nick, last year we were talking about how hot the market was, and the 1099 market was so hot. Everybody was getting all this increase in hourly rate. You could walk in and demand what you want. I think this year, kind of the better question is, how durable is the 1099 market long term? We've seen some shifts, right? And one of the things that we keep hearing about is equilibrium versus oversupply. And I know we've all been around a little while to the CRNA community, and we've been talking about this for the last 15 years or so, and Sharon might even say even longer than that. Um, are we truly moving towards this supply demand equilibrium? I remember they were projecting an oversupply in 2027. What's your thoughts, Nick?
Yeah, good afternoon, good evening, everybody. Thanks for having me on here. I think the 1099, the locums market is robust. And I think it's going to remain that way, for the foreseeable future, at least for the next, say 2 to 3 years. I think, there are some adjustments like you talked about, Jeremy. I think, it's going to favor longer term commitments to a certain extent, those kind of 6+ month assignments, right? But I think when you look at, the incoming generation's thirst for work-life balance, right? Their intolerance, to institutional politics, right? It kind of really yields this, almost head down approach to the daily work when they're on assignment, right? And what we find in facilities is that a head down approach, to the daily work, devoid of any politics, just get the work done and get out of there. From a facility standpoint, it really favors, productivity. I think another factor here, right, that needs to be considered is the CRNA compensation is at levels, that nobody could have predicted 3 or 4 years ago. And I think it's interesting to see, what CRNAs are doing with that opportunity, right? That financial opportunity and that asset. And you're finding more and more of them are becoming more savvy with financial and wealth management, certainly with your assistance, Jeremy, to the community. I think they're becoming more entrepreneurial minded. They're taking that compensation, and they're moving into the side hustle, whether it's opening clinics or alternative businesses, things that are unrelated to healthcare, right? These are property management stuff, land management types of things. And what you're seeing is these CRNAs are dropping down from the 40-hour a week, work week into the 32, 24-hour space, right? That 1.0 FTE, is now moving into the point 0.8 realm. And every one of those shifts that's opening up, is being aggregated to make room for yet another, 1.0 FTE. And so I think there's going to continue to be opportunity, for the 1099s and for the locums because there's this new, ingenuity and flexibility in that space. And I think the next generation coming in is definitely looking for something that really doesn't, interfere or conflict with that work-life balance. I think everybody needs to pay attention because there are legislative efforts afoot to be able to remove the ability to work 1099, right? New Jersey's legislation continues to gain general traction year after year, as they try and attack, the gig economy and the gig workforce because of the tax implications on the state and whatnot. And so while I think it's robust, everybody needs to pay attention because those legislative changes, can really be earth moving, for the states, that choose to pass them. Um,
Yeah.
if you want me to
Yeah.
touch on oversupply and equilibrium, I mean, we could dive into that a little bit from my perspective if you want.
Yeah, yeah. I mean, it's interesting because, I know we've talked about this so many times. And, I read a statistic the other day that 12% of CRNAs are planning on to retire by 2027. I know we're ramping up schools, and, Tracy will probably talk to that a little bit and the micro side of it. But that's a lot of people that are going to retire, by the end of next year. To me, that doesn't sound like equilibrium. What's your take, Nick?
Yeah, I don't, the term oversupply, in any healthcare provider, it's kind of a rough sell for me, right? When it comes to anesthesia providers, I don't subscribe, right? I'm glad to see that many applicants coming out of schools. And I think for some of the reasons that I mentioned earlier, and you did as well, Jeremy, right? The idea that there's going to be retirement, and age out to a certain extent, you're going to couple that with provider burnout, right? And then you've got, this newfound wealth by CRNAs that are, they're not working 8 days a week anymore. They're kind of dropping back. I know New Jersey at one time made a mistake and, calculated 80 hours and just assumed that that meant there was two, anesthesia bodies. And in reality, it was just one person working double time, and so they overestimated the workforce, right, in that calculation, which was foolish. But I don't subscribe to the oversupply thing. I think there's going to be plenty of opportunity for all those reasons that I mentioned. And while I can understand that it might be a little compressed, right now as the shift is still kind of working its way through, I don't think it'll be very long, maybe another 18 months before that starts to widen, right back out as the new normal sets in. So, I'm not in the oversupply camp. I think we're going to need every one of them that's coming out. Now, I think their place of employment may vary a little bit, right? And we could talk about, the anesthesiologist workforce and what it's doing and, how the model's shifting has implications on that. I think maybe, for the short term, those W-2 CRNAs that are embedded in their groups and in their facilities may find it a little more difficult to pick up that overtime because there's going to be a little bit of a crowding, to kind of balance out, the work week a little bit. But I think the need's going to remain. I don't think it's going to be a problem. I think everybody's going to find a home, and I don't ever think we're going to get to oversupply. Certainly not in the next 36 months.
Well, let's
Yeah.
talk about the anesthesiologist pipeline. There was an article that came out on Becker's Healthcare called "The Anesthesia Workforce Shortage Demystified," and the numbers are pretty compelling. What I would like to bring up, however, we have always said from the AANA that 88% of nurse anesthetists would choose the same profession all over again, right? In this article, it says that over 40% of them want to leave right now, right now. And what, over half of them are over 55. So, what do you think this is going to do to impact our practice?
Yeah, I think you're going to see, the downstream effects of the anesthesiologist pipeline and then their inability to keep pace, with the demand, I think is going to cause a couple of, things to shift around here a little bit. I think we're already starting to see it now where facilities and locations, are starting to move their business operations to states where they have greater flexibility over the anesthesia provider choice in terms of model, right? It's costing them more no matter which model they choose, but they need the flexibility. They need the option. The surgeons themselves are susceptible to burnout, and the consequences are dire. So, the idea of an orthopedic surgeon grinding out 11 cases a day just to be able to afford, a medical direction model with an anesthesiologist, it's unlikely. They're shifting their practice locations to places where they have greater flexibility over the workforce. So I think that's, an important piece of, where people are going to find employment. I think it has implications on 1099s and locums. The MD, supervision, medical direction model, how sustainable is it, right? We've been saying for years it's not affordable, you can't do it. I think sustainability is kind of a terminal, is seeking a terminal definition. I don't think it's ever going to completely go away. I think it's going to be around to a certain extent. I think, the anesthesiologists are going to drop back, to the hospitals and the institutions where their brand identity is a little stronger, right? They've been peddling this, we needed for the most complicated cases, and there's some academic adherence to the philosophy. And so, the new grads coming out, those 9,000, right, that are rolling in, they may find it a little more difficult to kind of find that first position, to get that first 3 years in acute care, take all the care, call they can, kind of a scenario. It might be a little more difficult, for them. But I think you're going to have attrition in other places when you talk about, the payer, mix in some of these facilities. You look at ophthalmology centers and pain management centers, even gastroenterology centers where Medicare, is the predominant payer, right? Those facilities are doing everything they can. They're getting squeezed by the insurance companies too. So, the trend away from out of network billing, right? Forcing everybody in network, has created conditions where they can't afford the anesthesiologist. Well, as soon as they shift, to the more cost effective CRNA only model, that anesthesiologist is now displaced and he or she's walking down the block, looking for the next job. And of course, they're employable. They're going to find a home, and I think they're going to find it, in those acute care facilities. So I think that attrition, favors opportunity, but I think it's really, the opportunity is going to be for those locum 1099 CRNAs, that really have refined those advanced skill sets, that have mastered the regional anesthesia, that have mastered POCUS, that are highly marketable, right? That are going to be able to live up, to the hourly, compensation that they're demanding, in the market. So I think the anesthesiologist pipeline is going to see some problems, and I think there's room for us to capitalize on that. Certainly for the most prepared, locum CRNAs with those advanced skill sets.
Yeah, and I read something not too long ago that they weren't filling all their residency slots either. I can't remember what the percentage was, but I thought it was pretty low. So, I mean, we don't want to beat a dead horse too much on that one. I mean, I think we all see the writing on the wall with that if you just look at it logically. I mean, Nick, the other thing that's going on in the industry is, we've seen this reimbursement compression and QZ billing, this little thing that has happened out there, a lot of scrutiny on QZ reimbursement. If margins narrow 10 to 15%, does this weaken the case for CRNA only models? I mean, every 1099 would probably want to know the answer to that.
Yeah, look, I mean, we deal with this in practice management all the time, right? And I think, get up to 90,000 feet at the high level and what the Blue Cross and Blue Shield plans in particular are doing, right? The idea of moving, to everybody, getting the 15%, reduction, I think that's going to look more like urban warfare, kind of block by block campaign, plan by plan, state by state, jurisdiction by jurisdiction, right? I think that's, how this is going to shake out. I think savvy, CRNAs and groups are going to lock arms with their clients, their facility partners, and they're going to start to push back on that because the downstream effect is going to be an increase in cost all the way, to the consumer. Now, the plans, that's an interesting scenario, right? Because they don't vary, the charge, the monthly premium that's coming from the patient, even if they pay $85 for a service instead of $100, right? So the idea of shifting to a CRNA workforce at a 15% reduction, actually makes them a curious bedfellow for us because they're going to favor that model because our independence lines their pockets. And while, they may not be the ally that we want, the enemy of our enemy being our friend here, as more and more of those plans pick up that 15%, reduction in reimbursement, we actually may find some interesting conversations available to us with those plans in terms of the advocacy front. So overall, logically, Jeremy and Sharon, I think, the 15% reduction, should, weaken the argument, that the CRNA is the most cost-effective model. But practically speaking, these facilities are deciding whether they open the room for the day or whether they open the facility at all based on the availability of an anesthesia provider, right? And the magic ratio for the 1099, locum CRNA is to figure out how much compensation you want to ask for in light of that payer mix, such that if a stipend is required, right, to support, your employment, the net result is a stipend that's still less than the stipend that they'd have to pay for the anesthesiologist at 100% reimbursement. That's, I think, the breach for the negotiation there. But availability is still driving this whole thing, regardless of the reimbursement. And if they do take us down 15% globally, again, I think it's unlikely. I think it's going to be block by block, plan by plan. But if they do take us down, all the way down that far just across the profession, then we absolutely are going to be the most cost-effective anesthesia providers from their perspective. And it'd be interesting to see what we can do that with advocacy.
That's a great point. And I'll guarantee you the anesthesiologist is making more than 15% of what the CRNA is making. So,
Well, either Tracy or Nick can answer this question for me. With the 1099 market, locums, is this going to be a permanent solution, or should people like me who are 1099 worry that they're going to start trying to rebuild a W-2 workforce and push us out? Because from the outset, it looks like we cost more money. So, Tracy, I see you smiling. Give me good news, brother.
Oh, well, I look, I think there's good news and there's bad news, right? The bad news is that yes, the employers and the hospitals, they want to go back to a W-2 workforce model. It's more predictable, more
Mhm.
sustainable. However, they won't be able to in the near term. So there's the good news. You'll be able to retire before that happens.
Okay, good.
Nick, you agree?
Yeah, I'll piggyback on what Tracy said. I mean, I think it's not going to be the predominant long term, right? But here's what we see happening, right? The hospitals and the facilities are competing for market share all the time, right? And they're getting quicker at standing up these ASCs and trying to expand their footprint. And, the health system's merging up with other smaller health systems, and they've got to keep growing and growing and growing, right? So I think just to sustain that, that thirst for growth, they're going to need to lean on the 1099, the locum providers, just to be able to quickly get that ASC up and running and making money, right? I agree with Tracy. I think the facilities are going to keep doing, everything they can to grow their W-2 workforce. It's just the transient nature of the workforce. It's hard. They don't do at least they seem to not do as good of a job of growing corporate culture, right? A little while ago when you were in these smaller anesthesia groups, you kind of knew your lane and, you had a culture, you had an identity, and the bigger health systems, yay, we're Mayo Clinic or rah rah, we're Cooper Hospital. But when it comes down to the departmental level, the anesthesia department, they're not very good at growing, corporate culture, and the new applicants are kind of looking for that. And so I think, you're in the era of the VMSs, the vendor management systems. I don't think the health systems are stupid. I don't think that they're going to get caught, like they did coming out of COVID when the elective cases came back. So I think they're always going to maintain as best as they can some degree of a bench of locum providers in there and then move them, to scale when a new surgery center or a new wing of the hospital or a new operating, pavilion kind of opens up. So again, I don't, to what Tracy's point is, I think they're going to do everything they can to grow the W-2 workforce. I don't think they're going to be successful at it in the short term. And I think there's always going to be that need, at least in the foreseeable future, for those locums 1099s, if for no other reason other than to quench their thirst for scalability.
Well, and I mean, we've seen it in our practice. We CRNAs are getting a lot of money thrown at them to go back to W-2. They're getting bonuses. And to me, it looks like a lost leader, right? It's like if we can just pull you back in, and I see them making what I would consider big mistakes. In fact, certain areas are saying, you can't work here if you live within 50 miles, but they were paying them $200 an hour that were local. And now they're bringing in somebody from across lines. They're paying them, $280 an hour. They're paying a housing stipend and they're paying for them to be there. I just don't know how the math on that works. So anyway, a lot of interesting trends that we're seeing. And
Well, one thing I'd like to throw in here because, all right, Nick, how long have you been in giving anesthesia?
Came out in 2010, so 16 years now.
Okay, Tracy, how long?
25 years.
Okay, I'm 35 years. And there is one critical thing different now that I see, and Nick talked about it and kind of glazed over it.
yeah,
But the new providers that are coming out, they're coming out and going 1099 because the number one thing they want is flexibility. And I love millennials, and I think they're going to change what our practice looks like. Used to come around 5 o'clock. Well, we got one more case to do. Well, Sharon, you're going to stay. They will not tolerate this. They want their time off. I think it's going to be good for the profession in the long haul, because they won't take the crap that we took, and they want their freedom. And so I think to answer the workforce, the 1099, they're going to demand it and they're going to get it.
I
And
agree
that's
with you.
just the world according to Sharon Pierce, not Jeremy Stanley, as it says.
That's right. Sharon said that, not me. But I mean, what we're seeing is these new CRNAs are so smart. I mean, this group of cohorts that are coming out are
Absolutely.
extremely bright, extremely intelligent. They know what they want. They're not afraid to ask for it. So, Sharon, Nick, I think you're spot on. But we better
Yeah.
move here because we're going to get bogged down. And Sharon, you know how long-winded I can get.
Oh, I know. That's why we put you at close to the end.
Well, I mean, I think we know the macro trends matter, but Tracy, the biggest thing for the majority of 1099 CRNAs out there are, where are the pay rates and the job trends and what does that look like? We know that 2024, the bill rates were extremely high. Are we seeing that stabilize? And what are we looking at now?
Yeah, I think we zoomed out, we looked at the macro, but all business is micro, right? That
Right.
all rates are going to be local, they're going to be different, and they're going to respond differently at different times to the marketplace. And what we're seeing, and what my trend, I guess, to stay on the macro for a moment, is I'm expecting probably a 5 to 10% increase for 2025 from 2024 for 2025 to be seen. That data should come out a little later this year with the survey, the compensation survey that the ANA puts out. But back to the micro level, there are many markets that are actually starting to stabilize. They may be still ticking up, but slowly and not quite as rapidly. And then there are some that are still rising rapidly. And local markets are going to do what local markets do. There's a lot of variables that will influence what happens in those areas. The number of programs in that geographic region, the expansion of the region. I mean, there's populations are moving all around the United States. There are some cities right now that are building ASCs and hospitals as fast as they can. They need CRNAs to go in and staff those. So um, that surgical demand has continued to go up, going up. One thing that Nick mentioned when we were talking about the anesthesiologists, their numbers, our numbers are going up and to the right, and their numbers are going to the right and not really up a whole lot. So they're in the very near future, there's going to be a lot more CRNAs than anesthesiologists. And we're going to start seeing a sorting in the marketplace. There are going to be hospitals that they're going to choose an anesthesiologist heavy model, and then there's going to be a whole bunch of them that just won't be able to do it. Then you start factoring in, we talk about our workforce issues, surgeons. Surgeons are about to hit a crisis level as well too. So there's a lot of variables that's going to go into the next 3, 5, and 10 years. And I wish I had a crystal ball that I can shake and it would spit out the perfect answer. But in general, we're still seeing increases in 1099 compensation, not quite from what I'm seeing anecdotally. I'm in 6 states, and I keep my finger on the pulse of, and a lot of others. I speak at probably 20 or 30 states every year. And people kind of talk to me about their rates, and I'm seeing it still going up, but not as fast as last year.
So what are the hot spots? You said that there were places that were still growing and still
Yes.
needing 1099s. Where are they at?
Absolutely. So there's small pockets all over, right? And sometimes it's very, very locally dependent on kind of what's happening with groups and group turnover. However, geographically, the Midwest, we're seeing rates continue to go up and go up in the Midwest, out west as well too, in the West Coast. I was in the COA offices maybe a year or two ago, Sharon. You've probably seen the map. They have pins where every CRNA program is, and
Mhm.
there's a whole lot of pins between the Mississippi River and the Atlantic Ocean. And there is not a whole lot of pins
Right.
between the Mississippi River and the Pacific Ocean. So we're just not graduating as many students in that area. And consequently, there's also population movement into those areas as well too. So that combined, we're seeing increasing in rates in those markets pretty rapidly still.
Yeah. Tracy, are we still seeing, I mean, are you seeing people struggle to get folks in now, or are we loosening a little bit, or is it kind of regional and local as well? I mean, is that kind of the same thing? Because I mean, pretty much everywhere I've seen, CRNAs are still kind of driving the bus, but in the bigger cities, it seems like the less we're seeing the opportunities right now.
Yeah, I think that's a fair assessment. I would take it down even to the hospital level. You may have we call it 150,000 community, maybe 300,000 population community, three, four, five hospitals, three, four, five ASCs. There are going to be one or two that's going to struggle, and the rest may be fully staffed, or at least, if not fully staffed, every room is going to be covered every day, whether it's a mix of W-2 and 1099. And then I mean, you go to the hospital level, there's some that they're having to cancel 4, 5, 6 rooms a day because they can't get providers to go in there. So is that a workforce issue? I counter it's probably a structural issue at that hospital and a cultural issue in that
Absolutely.
hospital and how they treat people. There's still a shortage, right? However, the shortage is people are talking with their feet. And the ones that are struggling are the ones that have cultural issues. They don't treat their people well, and then they're having to shut down rooms. And that's expensive for hospitals.
Yeah, Randy Moore talks about that a lot about culture, and I think you are right on the money. In my area where I currently live at, there's hospitals down the street, and they are paying out the nose for people to work there, but their culture is terrible. I will never work there. Well, let's talk about productivity pay models. And in this, I'm telling you guys, this article from Becker's was very informative. And one thing that is talked about in there is that productivity, even with the surgeons, in some places are making the surgeons pay if they don't meet their block.
Yeah.
So let's talk about within the CRNA community. Are they going towards productivity models versus flat rate?
I'm not seeing it yet. I've heard talk about it. There's been, there's ideas floating around surrounding the productivity model. Where I struggle is that I think there's a really good case for rewarding high productivity. In other words, if you're gonna bang out 12 cases in a day, there's a really good case to reward that provider for that. The problem is so many facilities have really, really poor um, utilization, right? I mean, a
Mhm.
CRNA may only spend 30% of their day actually doing anesthesia in an 8-hour day because of long turnover times, because of these inefficient flip rooms, because of surgeons that may not be show up on time, or they show up at noon, or they go and do one or two cases and leave and go to an ASC or go to their office, and then you sit around for 3 hours before your next case. So the problem with productivity models is we're a bit of a victim in that situation. And how do you, is it, if you're gonna, you can't be punitive to that provider, right? That just wouldn't work because that provider would just go somewhere else where there's no productivity model. So it's finding a balance of rewarding the high productivity, but also where we can control productivity. There's a lot of levers that we don't pull when it comes to productivity. There's some, but there's a whole lot that's outside of our control.
I absolutely agree. Um, so we've talked about a couple of things. Well, number one, culture. What are some other factors to evaluate beyond hourly rate if you're looking at going to work at a place?
Yeah, great question. When I finished school, and for probably at least 10 or 15 years after that, there was always a saying that you can get three things in an anesthesia job. You can get location, you can get compensation, or you can get autonomy and respect, right? Those were the three things, and you'll never find all three. If you can get two of the three, you should take the job, be happy,
Right.
and shut your mouth, right? And
Yep.
like that was the mindset for 15 or 20 years. It's so much more complex now. Work-life balance, number one. Um, the autonomy and respect is always one or two in every job satisfaction survey that comes out. The amount of time off, flexibility in schedules, flexibility on when you get to leave, what shifts you get to pick up. Right now, when we try and hire for 5/8s, it's really, really difficult to hire a CRNA to work 5 8-hour shifts Monday through Friday, 7 to 3. That is a non-desirable shift for many CRNAs now. I'd say for the majority. Where in the old days, that was what was
That was it.
expected. That was it. That's what you did, right? And so now, like, and back in the old days too, if we had 24-hour OB shifts, nobody wanted those. Now, those are our easiest positions to fill across all of our sites across 6 states, 150 hospitals. If we have 24-hour OB shifts, we have people lining up to take them because they can work 7 shifts a month and then pick and choose what they want to do. The other, I'm not good at math. What is that, 20, 17 days a month or whatever to do what they want to enjoy time with their family, work extra locums and 1099 and pick up some more shifts. So it's that flexibility in those 10-hour shifts, 12-hour shifts, working 4 days a week. Those are important to look at in a job as well too. And then feeling like you're part of a team. It's probably really it's it's an underestimated aspect of being in a job, but I think we've all seen cultures. I mean, this could be lumped into culture as well too, but we've seen cultures where everybody's in it for themselves and like everybody's like trying to go home early. Everybody's trying to pick the easiest cases. And like, but when you're part of a team and everybody's working together and you're like, oh, your son has a t-ball game tonight. I'm gonna stay late for you. And like just that culture of cohesiveness, it's amazing. We spend more time with our work families than we do with our real families if we factor out sleeping time. So being in an environment where your work family is supportive and you feel like you're part of a team, I mean, for people looking for jobs, I think that's an underrated aspect of it as well.
Now, this is kind of off this topic, and it's something I deal with all the time. Credentialing. Credentialing delays in trying to go to a new place to work. I'm going to stay some of my time in Minnesota near the grandchild, and I thought I was going to work. Oh my God, trying to figure out where, get credentialed. It can take 3, 4 months to get credentialed somewhere.
Yeah, yeah, absolutely. Total pain in the rear. Um, and there's no
Again,
real
we're a
shortcut.
victim.
We're
Again,
a
we're a
victim,
victim.
right? With primary source verification, every hospital has to go back and redo the same work of every hospital you're already credentialed at. It's an inefficient system, and there's a bunch of people trying to solve it. But the system is so inefficient and so big, it almost perpetuates itself. Like it's so hungry for a solution, but it's so big and so complicated that
Mhm.
everybody just ends up throwing up their hands. Like CAQH was supposed to be a solution, and there's I don't know how many vendors that do credentialing services for hospitals. None of it's worked. It's a
Yeah.
total pain. Some hospitals have gotten better at it and they can get you credentialed in 30, 45 days, especially with temporary privileges if you have a clean record and some of the other stuff. But for the individual 1099 CRNA, my advice is make sure you keep all your work history clean and clear. Keep all of your documents, your certifications, your ACLS, everything up to date and in a folder where it's an easy click, drag, and out the door. So you don't have to like spend a whole lot of time reinventing the wheel every time.
Yeah. We have interviewed a couple of groups where the CRNA, they've created a company where you can house everything. That helps out a little bit. But anyway, Jeremy, you can ask a question now. I'll let you.
That's okay, Sharon. I know how this rolls. So, well, I think we could talk to Tracy and Nick all day long and probably not get all of our answers that we'd like to have out of them. But I kind of want to shift gears again, bring John in here. I mean, compensation seems to get a lot of the attention and people want to know about that, but it's really contracts that determine that compensation that CRNAs actually keep. And the big thing is that flexibility. So, John, are you with us? I know his voice is going out on him a little bit, so we'll give him a little bit of a reprieve here.
I think we'll be all right. I'm going to do my best.
Okay, well, good. Well, what are you seeing in 2026? What are some of the trends and things CRNAs really need to understand about contracting this year as a 1099?
You know, it's interesting. It's fun to listen to Nick and Tracy talk and talk about all these things from you know balance and work life and compensation and culture and flexibility and all of these wonderful things. And you know, especially some of the more difficult things, right? People want that good culture, right? They want that respect. They want, you know, some of these, and those things aren't things that are documented in a contract, right? And so we talk about contracts, all day at Contract Diagnostics, and we help physicians, understand what they say and what they don't say, and then how to ask good questions around them, right? And these are things that just don't come up in contracts. And I think some of the things that were we see, the contracts, they don't change a lot from year to year. We do see, there's a big difference, of course, between a W-2 contract and a 1099 contract. And one of the things that make that 1099 contract so important is the flexibility in it. And I think it's important to understand, who's structuring schedules, how flexible are they. Exclusivity clauses can be vital. So if you're a 1099 contractor, you should be able to go do what you want, right? And have unlimited ability to go do what you'd like at other places and kind of spread your talents and your services and your time elsewhere. So as far as like trends though, we don't see a lot of big trends from 2024 to 2025 to now 2026, specifically in CRNA contracts. Of course, we see compensation change. We see, notice periods growing a little bit. And so, what used to be like a 30-day notice period maybe has grown to maybe a 60 or a 90 or even longer notice period as far as somebody wanting to give notice of leaving a position. And I think that's just from what Nick and Tracy talked a lot about, which is on numbers. People need these staff people. And how do you get people to stick around longer than maybe they want to? Well, you have a longer notice period. So instead of having them just be able to terminate in 30 days, it might be 90 days, it might be longer. So that's one of the big important clauses I think to look at as people look for that flexibility, that we're seeing maybe more of a trend in 2026 and 2025 than we did before.
Yeah, well, John, I know you and I have talked about this before, but my wife is a CRNA and she was working at a particular facility the group that had the facility lost the contract. She enjoyed working there, wanted to stay with the physicians and so forth. Another group came in, took over, and unfortunately, she could not stay working there, even though they lost the contract. And as much as we talked to them, they would not change their mind. They didn't want anything to do with that. They brought new people in. Um, I mean, those type of things are things that I think your average CRNA out there, you don't think about those things, right? I mean, my wife's a smart woman in CRNA, but those are not things that CRNAs are adept in managing and so forth. And I think to your point, you've got to learn that you need some help, maybe reviewing those and make sure you understand the terms and so forth in there.
Yeah. Well, and also understanding, what questions to ask. I don't think we've seen a contract that says, we have a contract with, we see contracts that say, it might be your contract and employment or contracting role might be contingent on us having a contract. So of course, a really great question to ask is, when was the last time the contract was negotiated? When is it up? What are the terms in there? Could the hospital or the facility terminate the agreement, and how much notice is that going to give you? And has that happened before? And then what happens? What would be my role in that, right? Would I be roll over to the new organization? Would I have an opportunity to interview? What would that look like? And so again, things like that we don't see documented in contracts, but that's why it's really good, important to do full due diligence on every opportunity and ask really good questions.
Well, let's go down the path of non-competes. Jeremy just alluded to it. There's been a lot of talk over the last year or so. Are they enforceable? Apparently, in this particular instance, it was. Are they now? What's happened?
Well, I would comment on enforceability or not. I would say if they're in a contract, of course, follow them. I think it's really important that everybody understands the nuances in their individual states. What would they put in a W-2 contract versus a 1099 contract? And then how is it enforced? Is it enforced in any situation? So for example, if I was a clinician or a provider negotiating or clarifying a contract, and there was a non-compete provision in there, and the non-compete, read very clearly, this is in place no matter what. A really good discussion topic or a question would be is, how can that be fair? What if you lose the contract? That's not my fault. What if you terminate me without cause? That's not my fault. What if I terminate for cause? That's not my fault. And so there are ways I think that you can delineate that non-compete and maybe have it be a little bit more fair in the agreement. But we would always say if there's a non-compete in the agreement, 100% follow it. And are they enforceable? I think there's one way to find out and see if they're going to enforce it or not. And that's not something that most people would like to do.
We'll talk about termination clauses in contracts. Have they changed, or 24, 25, and heading into 26? It's the same.
Yeah, it's the same now. Well, a little bit. So, like I said before, we're seeing a little bit more lag notice, so what used to be a 30-day, notification. I want to leave this position. Here's my 30-day notice as a contractor. We're now seeing it be longer. We're now seeing 60 or 90 days or 120 days. A
Mm.
contracted position shouldn't, in like W-2 employment, what we're seeing is maybe no cause termination. So you might not be able to leave. Now there might be like a term. So maybe the term is it's a 1-year term or a 2-year term or a 3-year term, and the contract might say, you can terminate at the end of a term, or it might say you can terminate with 60 days notice after the initial term. And so it's really important to know what that initial term is. So we've seen that both in physician contracts and CRNA contracts and PA, NP contracts, is that in W-2 employment position especially, we're seeing some of those notice periods not even able to drop until that end of the initial term. So it really does matter if the term is a 1-year term or a 2-year term or longer.
So, what are, say, three top takeaways that CRNAs who are listening need to know whenever they're negotiating their contracts?
Well, I would say, negotiation is really important, but I would say it's also about, like I said before, it's about clarification. It's about due diligence. It's about having really good questions to ask at the right time before you jump into a position. I think, many people, and I don't think many CRNAs fall into this, but I would encourage them not to if they have in the past, is, what we see with a lot of people, they'll discuss, negotiate, their compensation structure. And then they'll sit down until the employer comes and brings it back up. And I think it's always good to have, to keep up with the market. Tracy and Nick talked a lot about compensation and rates and what they're seeing in data, and what the AANA data we'll see coming out, and what MGMA data has coming out, and what we have at Contract Diagnostics for data. I think it's really important to keep up on those market trends and know that you can raise your hand and discuss your compensation anytime, especially as a contractor. Dr. Catherine, who is our director of education here, and she's an OBGYN physician, but she told me that when she was a locums, she used to negotiate her locums agreement depending on the situation every few weeks, every few months at a minimum. But she would never just sit in a role for an extended period of time and not have any changes. She would continue to push and continue to press. So I think of all these things that are important. I think when it comes to negotiation, I think number one, it's making sure that you're keeping up on your compensation. And then, of course, number two, making sure that you understand everything in the agreement. So I think that agreements are about expectations. What are you going to do for us? And then what are we going to do for you? So typically, the clinician will provide their time and their expertise, and the facility will provide compensation and a place to work. And of course, all those other things, if it's a contractor, who's providing malpractice insurance, and who's providing equipment, and who's providing all these other things like benefits. But I think it's important to understand what those expectations are, and those things should definitely be documented in the contract and be so very clearly.
Yeah, I think something else, we'll spend some time talking about this, but certain places are now requiring workers' comp, and that should be in the contract as well. We've had CRNAs that had worked in facilities and then come back 6 months later and they say, "Oh, they said I didn't get my workers' comp. They want, so things like that need to be negotiated in there too."
Yeah. Well, and when it comes to rates, is there a differential for overtime? Is there a differential for holidays?
Yeah.
If you have paid leave as an employee, are those hours paid out if you don't use them, or do they just disappear? So again, there's lots of those nuances that you might be paid a set rate per hour, but there might not be any detail on holiday pay, or excess pay, or fill in the blank. And I think all those things definitely need to be discussed and documented appropriately.
Yeah. Well, another real life example, we had a client come in, late last year, and he was working at a very small hospital, taking call. I mean, it was CRNA only. A particular group was staffing it. And we start talking about how much his hourly pay was. And he said, I'm making $145 an hour. And I about rolled over in my seat. I said, 145? I mean, at least we're seeing at least 225, 230 in this area. He said, "Are you kidding me?" I said, "No, you need to go back and renegotiate with them." And he did, and he got him up to 200. He was just elated that he got him up to 200. I was like, "You're still below the market," but but paying attention to that. And Nick, I think you raised your hand. Did you have a question?
Yeah, over at UltraCare, we have a 6-state footprint up here in the Northeast, right? And while, John's on the call here, we can have the conversation. One of the things, whether it's, our groups down in Florida all the way up to New York, it doesn't matter. One of the things that we see CRNAs come to us all the time when we take over a new facility or acquire a group is the difference, or at least being able to distinguish between the differences associated with non-solicitation in a contract versus non-competition in that contract. And lots of CRNAs struggle with that. At UltraCare, we don't use non-competition, it's non-solicitation, but we find a lot of CRNAs that don't really understand the difference. They're just afraid of both because they don't know the difference. So I didn't know, John, if, or if the audience, Sharon and Jeremy, would find any benefit from understanding those are different things, right? And maybe John could just shed a little bit of light on, some of the finer details, the differences between those two things.
Yeah, what we typically see in contracts, a non-compete will be defined as a radius. It'll be, defined by geography. So it might be county-based or radius-based. It might be account-specific, and time-based. And a non-solicitation is not saying you can't compete, but it would be who you can't solicit, right? And we see everything from non-solicitation of payers to non-solicitation of other contractors or employees or other facilities, And so, yeah, what it all comes down to what all you can do and can't do, both during the contract period, right? And then afterwards. And then for how long does that last? But a non-compete may just say you simply can't work for 5 miles or 10 miles or 50 miles. A non-solicitation might mean who you can't talk to and what you can't do, not being employed or not being contracted with another facility, including your colleagues.
Good points. Great point there, Nick. And John, thank you. You made it through. Your voice held up. And now Sharon's going to introduce our next speaker while that speaker actually potentially puts something on the screen here. So.
Well, of course, it is the illustrious Jeremy Stanley. Now, let's see if we can keep him within his time frame. He's going to talk about taxes. Oh my gosh. And financial planning updates, which we are all interested in. And I guess we're getting ready to come up on tax time. And I'll see less and less of Jeremy for a while.
Yes. Fun time of the year for all of us, especially on the 1099 side. And, the environment has somewhat changed this year in light of the Tax Cuts and Jobs Act being made permanent last year. It basically stabilized the tax rates for now. The good thing is that the majority of us did not get a tax increase like we probably would have if they would have extended the Tax Cuts and Jobs Act. So that's a very positive thing for us for our bottom line. I think it's also important to understand, some of the ramifications of that also. We get a lot of folks who are looking for tax deductions throughout the year. And, one of the things that we get a lot of questions about is depreciation, bonus depreciation. We have a lot of CRNAs that are buying automobiles for the business and actually got bonus depreciation restored. So now you can take 100% of the purchase of a vehicle that's used for 100% business, which we'll talk about in a little while. If that vehicle is over 6,000 pounds, you can actually write it off in that particular year, whether you paid for it or whether you financed it. So you can imagine, Sharon, with the price of vehicles today, if you could take $80,000-$100,000 off in 1 year for the purchase of a vehicle, that might lower your tax bracket a little bit. And we see a ton of CRNAs doing this. I'm going to talk a little bit more about this in a little while because it can also be a flag if you're not doing it right. And we are seeing, the IRS. I know people think the IRS has been gutted and, you never have to worry about them and so forth. We hear a lot of that. But we are seeing some compliance enforcement increase in certain areas. And, one of those I'm going to spend some time talking about here in just a minute as well. I think the theme is going to be is that the planning and integration that it takes to be a 1099 CRNA. I mean, listening to Nick talk and Tracy talk and John talk, and we're going to hear Brian talk in a little bit, but, integrating and planning amongst all these things and making sure everything is working together for you as a 1099 CRNA, it really increases the likelihood that you're not going to make mistakes, not going to have errors, and hopefully better your own financial situation from either paying less in taxes, putting more away for retirement, putting more in your pocket, traveling more, doing whatever you want to do. And I think the whole theme of all of this, and the reason we started doing this was because of that integration piece that was really missing in the CRNA community. So Sharon, anytime you want to chime in, that's fine. You want me to keep rolling, I'll do that too. But, another area that we get a ton of questions about, and quite frankly, a lot of CRNAs don't transition to 1099 because of the health insurance situation. We are seeing health insurance rates for families out there reaching, $1,800 to $2,500 a month. If you're going out on an exchange plan, that's a lot of money. But what's the option there? You've got to weigh that when you're looking at potentially transitioning from a W-2 employment situation to a 1099. You've got to build that in. I mean, the good thing is if you structure it properly, that will be a deductible expense to your business. But a lot of people, there's a lot of confusion about this. One way to get health insurance is when you leave your position is taking COBRA. You can COBRA for 18 months. For some people, maybe that's the best option for the short run. I had a CRNA the other day. She's taking a particular drug. It's very, very expensive. Unfortunately, the exchange plans wouldn't pay for it. She's planning to retire within 18 months. So it worked out better for her just to pay the COBRA rate, continue to get the drug paid for through her current coverage. So it really just depends on, what your preferences are and what your needs are, how you get health insurance. You've got the ACA in the marketplace. Just remember, you're guaranteed to get coverage out there. They cannot discriminate against you for, having diabetes or having had a heart attack or anything like that. You're guaranteed to get coverage, but that coverage is going to be fairly expensive. And the majority of CRNAs are not going to qualify for subsidy. You just make too much money. And actually the subsidy environment has changed even since last year. So CRNAs that maybe slipped in under the wire last year are not doing that anymore. So signing up under your spouse, or your partner, if you're married, you can do that. That might be the most cost-effective way. That's kind of my double your income approach to being a CRNA. And also save on your health insurance costs. One's W-2 and one's 1099. Works perfect. And you still can go to some direct provider plans, Blue Cross Blue Shield, United Healthcare, and you can contract with them directly. Another one that we've seen is the health share plans. They're not really health insurance, but it's a way you actually share the cost of health insurance. Some people are very weary of these. They are a lot cheaper. If you don't have a lot of health problems, they can save you a pretty good amount of money by doing that. But just remember, they are not health insurance. The contracts, as John said, are not there and so forth. So you got to be real careful about that. I think, we're looking at options for CRNAs. There's more potential out there right now for association type plans to potentially make a comeback. There might be some of those type of things that could potentially be on the horizon. We're checking into that now to see if any of that might work for CRNAs. But the landscape is changing, and it's got to. I mean, most people can't afford to pay $2,000 or $3,000 a month for health insurance. So, the other thing that we get a lot of questions about is disability. I'm just going to leave it at this. Make sure you've got an on-occupation disability policy. That basically means that, you can't do the substantial and material duties of being a CRNA. You don't have to go back and be a bedside nurse. You don't have to go flip burgers at Wendy's. You're going to get paid what they said you're going to get paid. A lot of different types of plans out there. We're not here tonight to pitch any of them. I just find that with CRNAs that are 1099 or going 1099, this is one of those holes that need to be addressed because you guys are the goose that laid the golden egg. If you don't work, you don't get paid. So making sure that you've got this secured is very, very important. So another thing that we hear a lot about and get a lot of questions about is the S Corp still the right tool? Well, as in everything, the answer is what, Sharon?
Money.
It depends. Money as well, but it depends.
It's still about the money, Jeremy.
It's still about the money. You're right. So, I think the S Corp, whether you're an LLC or PLLC with an S election, it makes a lot of sense in most cases. It's a powerful tool. You need to understand it. You need to understand when to use it. One thing that we're seeing a lot of interest in from the regulators, meaning the IRS, is reasonable compensation. And there are so many theories out there. It's funny, I'm on these Facebook boards and I see CRNAs throwing stuff out there about it. I've talked to my attorney, I've talked to my CPA, I've talked to this person. This person says it's a ratio of this. Um, I'm going to tell you what it is. It is whatever you're comfortable explaining to the IRS if they ever came knocking on your door. And I always tell this example of a CRNA out in California, Podunk, California, working, made $500,000. And the CPA told him that $50,000 was a reasonable salary that he was working with. And I said, wow, okay. I said, well, are there any other of these positions out there? He said, man, he said, there's probably 3 or 4 that I know about, that they're paying that out here. I said, that's great. I said, I know a ton of CRNAs. Why don't you and I go into business together? You know where these opportunities are. I know CRNAs. We'll get them to work at these facilities. We'll pay them $50,000 a year, and you and I will split that other $450,000 on these CRNAs, and we'll make a lot of money that way. And he goes, who in the world's going to come out here and work for $50,000? I said, exactly. How are you going to explain that to the IRS? So I just encourage people, when you're setting reasonable compensation, when you set it, have a reason, document the reason, how you came up with it, keep it in the file. And if the IRS or anybody ever comes knocking, here's how I came up with what I got. Is it reasonable? And CRNAs are smart people. You're very analytical. You're going to know right off whether that's reasonable or not. And I'll just leave it at that. So the other thing about an S corp is there is more administrative burden in the S corp, meaning there's lots of things you have to do to have that S corp. One is you must pay yourself a salary, and um, there's got to be enough money made in the corporation to justify and offset the costs of additional tax returns and additional things you've got to do. There is no rhyme or reason to that. Usually, what I see is if you're around that $100,000 level, it starts to make sense to be an S corp. But that is not, and I'm not giving anybody any advice. I'm just saying that's kind of where we start to see it starts to make sense to potentially look at that. um, and that income level does really determine whether it's effective or not. We'll talk a minute about QBI and how the S corp fits in, but that's whole completely different story there. So
Just to give you an example, my first year of 1099 work, and it was just me. That's it. I was a PLLC. The next year I went to a S corp and it saved me $28,000 in taxes in 1 year.
yeah, and it can, depending upon how you structure it and the things you do. That's for sure. One of the other things that I want to make sure we get to tonight, because I think it's overlooked and people aren't talking about it, is basically when you go to itemize your taxes, one of the things that you can itemize is your state and local taxes. And up until last year, that was set at $10,000. And for the majority of us out there, we're paying more than $10,000 in state taxes. You add in local taxes, and it becomes a lot more than that. Well, one, that amount has moved to $40,000 this year, so that's good. But there is even a workaround. So if you're paying more than $40,000 in state and local taxes, um, actually, this goes back to 2020, but a lot of CPAs don't talk about it. A lot of CRNAs don't know about this. You can actually utilize this pass-through entity tax election, and you can pay your state taxes through your S corporation and deduct all of that because it's not subjected to that $40,000 cap.
Yeah.
So, talking to your CPA, understanding that, making sure they're doing these things, again, just an education thing for CRNAs out there to put some money in your pocket. These things are legal, and you want to make sure that you're doing them.
And it works. I did it.
Works. Yeah.
I did it. But what I did wrong is I initially paid in quarterly under my husband and I filing jointly. And then so I had to pay my state taxes for an entire year through my corporation. And so then I just had to wait. I got that money back that
Yeah.
I had paid in quarterly. So,
Yeah. Yeah, and that's a really good point. Each state, there's I think 36. I know there's 30 some states now that allow this. There are different time periods that they want you to pay this, whether you pay it quarterly or whether you pay it
mhm.
annually. So you need to be aware of that in your particular state. So Sharon, that's a really good point. So. QBI, if you've enrolled in the 1099 Institute, you've taken the class, or if you know anything about QBI, we talk about this a lot. Qualified business income. I think it's one of the most amazing tax deduction strategies that have been brought about in a long time. It basically allows the profit in your company to be taxed, 20% of it to be taxed at zero if you qualify. Unfortunately, CRNAs and people that do what I do, we're classified as a specified service or trade business. So they actually put thresholds in for us to where we can qualify for this particular deduction. Um, and I've got them up on the screen. That's the reason I've got slides, because a lot of this is numbers and so forth. But I wanted you guys to be able to see it. Both of those phase outs have increased dramatically this year. So married, file, and joint, it starts at 403 and goes to 553, and single 201 to 276. If you've got an S corporation, QBI is one of the reasons that can define whether you should be an S corporation or just be an LLC. And I'm not going to get into too much detail, but it is a conversation you need to be having. If your income is dramatically over this amount, or even close to this, remember you get a deduction at the corporate level for paying yourself an income. But if you are an LLC and you don't need that deduction, in other words, you're not making as much, the LLC will allow you to actually get that 20% on the amount you would have paid yourself as a salary under the S Corp, if that makes sense. So sometimes it is better, if you look at everything combined, for folks to try to get the QBI and just be an LLC instead of an S Corp. So many CRNAs don't understand this. They don't understand these phase outs. Their CPAs aren't giving them this knowledge. There are things you can do to reduce that income that will get you the QBI, and you need to be asking those questions of your advisors out there. Again, just want to make sure everybody understands that.
Jeremy, somebody asked the question, is this phase out total income or just S Corp profit?
It is total income. Total income. And again, I could talk all night about that, and the hour session on it, but it is complicated. I just want to make sure everyone understands. They need to be understanding enough to ask the questions. Something else we're seeing out there is a lot of CRNAs are working in multiple states. And unfortunately, I'm not sure where they're getting the information, but I just want to clarify, if you work in multiple states, you are supposed to file a tax return in each state that you worked in. Unless that state has reciprocity, meaning they don't require that, they have reciprocity with your state, and there are some out there, you need to understand that. You should be filing your return in each state that you're working in. I know a lot of CRNAs don't do it. But we're starting to see states cross-reference 1099s to try to identify any income earned within their borders. A lot of non-resident returns and local taxes aren't getting paid out there, and the states know that. So they're trying to crack down on it. The problem is that they might not catch this for 2 or 3 years. I know here in North Carolina, a lot of times we get notices 2.5, 3 years later. They've just gotten around to stuff here. And I know other states are the same way. But you accumulate interest and penalties quietly for a while, and then all of a sudden there's this abruptness of you owe us X amount of dollars, and we want it. Again, I just want to make sure that CRNAs understand that multi-state tax risk is out there. And another thing is if you're working in multi-states, you're an S corporation, make sure that you are also filing in that state your corporation, to let them know you're working in that state as well. That is often overlooked by CRNAs and their advisors as well. So just some basic housekeeping things there that I wanted to make sure we're starting to see more and more of the risk out there.
And even those who know may forget, Jeremy Bump reminded me because I thought I was going to be working in Minnesota this coming up summer, and I had not filed my company, but I have, Jeremy. It's
Yes.
filed just
Good.
in case I work.
All right. All right. I'm going to run through this really quickly. I know a lot of people have heard us talk about this, the solo 401k, retirement plans. These things start to make sense. They help you meet that QBI level. All this stuff is intertwined. Annual contribution this year of 72,000, 80,000 if you're over age 50. And then they put in this new little caveat now that if you're between 60 and 63, you can save $83,250 in your retirement plan. And then I know people have heard me talk about defined benefit plans as well. We have CRNAs that are making a lot of money right now, and you can put over $200,000 a year away in there. Again, lowering that income to qualify for some of these other deductions and so forth. Just remember, though, when you do these strategies, your cash flow does have to be there, especially on the defined benefit plan. Because you need to keep that plan around for several years so you're not questioned by the IRS. One more strategy out there is the mega backdoor Roth. I see people asking about that on the Facebook groups and so forth as well. Basically just means that if you're not meeting that $72,000 or $80,000 limit because your salary is lower, then you can actually do a non-deductible contribution into your 401k plan and then convert that immediately over to a Roth 401k contribution as well. So that's the mega backdoor Roth. Again, that gets a little complicated, but it's one of those things that if your income is limiting you getting to that annual contribution limit, because remember the profit sharing piece can only be 25% of what you pay yourself as a salary. Another way to get to that and actually get more Roth money in the plan is to do this mega backdoor strategy. A lot of information out there about that as well. Again, I just wanted you guys to hear the terms and know about it. Some of the things we're seeing, audit red flags. One, I want to go back to the vehicles. I mentioned this earlier, personal versus business use. If you are buying a vehicle and you are writing off 100% of that vehicle as a business vehicle, you need to have another personal vehicle licensed in your name. The IRS is never going to believe that you never use that car to go to Walgreens, to go out to eat, to pick your children up. If you don't have another vehicle for personal use, you should not be deducting 100% business use of that vehicle. Something else I'm seeing a lot of chatter about is the Augusta rule. People are applying that rule to them personally. It was really meant to start out for people that rented their houses out. And if you rented it for under 14 days, you could rent it for a certain amount of money and not pay any taxes on it. We see it around here because High Point is the furniture market capital of the world. People rent their houses out. They rent it for $2,000, $3,000 a day. They put in 30, 40 grand in their pocket a year. That's been turned a little bit because now you can also rent your house out for business meetings at fair market value rates. I'm going to tell you, for most CRNAs, this is a stretch to use the Augusta rule, but make sure you're documenting what you did, why you did it, what the purpose of that meeting was, who was at the meeting, and so forth. A lot of information out there about that as well. So other triggers, the IRS, because everybody wants to know these audit red flags. In fact, we've got a whole list of these that I've put together, but, consistent loss in business. If you've got round numbers on your tax returns, and a lot of them, the computer will flag that. If they take your industry and you've got atypical ratios, again, that flags. A lot of times the way an audit starts is the computer spits it out, and then there's one thing, two things, and then they get assigned to an agent, and then they start looking into other things. So if we can keep off of the computer pattern screens, a lot of times you can avoid an audit that way as well. So um, other mistakes we see CRNAs making: lifestyle inflation. See that all the time. Income increases, spending increases faster. You do that, you never accumulate wealth. Not having an exit strategy, whether that's exiting 1099, whether it's exiting W-2, or whether it's retirement. Make sure you've got a strategy there. And then, as I said earlier, just the fragmented planning. All these things go together. If you haven't seen that tonight, we haven't done our job. But talking from the employment market to hourly rates to where's the market going to why am I doing 1099, what's my purpose, to how do I handle the contract piece, to the last part of this that Brian's going to talk about here. And one of the most important things is the insurance piece. And I'm going to switch it up here and let Brian take it from here. Sharon, I've done enough talking. It's your turn.
Pardon me. Well, Brian, you have been waiting patiently tonight, and we appreciate it. Brian's with the AANA Insurance Services, and for those of you who are 1099, you should not get your insurance anywhere else because there are a lot of reasons why you shouldn't. But let's go ahead and jump right in with you, Brian. And some people are kind of grousing out there because of premium increases across the board. What's driving the rise in malpractice premiums in 2026?
Yeah, thanks for having me. Thanks for the question. So, claims in a short answer, and there's a few reasons around it, but we're seeing a much higher frequency of claims, and the claims that are out there are of higher severity. So there's more of them, and they're higher, and there's several reasons why. We're also seeing CRNAs being brought into claims more frequently than they used to be. Um, I think in the past I mean, there's always been just anecdotally more goodwill towards CRNAs, and I think that for whatever reason, plaintiffs' attorneys are turning away from that, and we're seeing multiple professionals that are in the room when something happens, being brought into claims where in the past it might have just been a doctor. Um, we see some very specific scenarios where CRNAs are at times the only ones in the room that have insurance. That's more of a state by state case. And we also see other cases where CRNAs might have higher limits than other medical professionals in the room. So there's more of a target on their back for the attorneys to go after. Um, Regional considerations also come into play. So there's a thing called jurisdictional hellholes. There are different places around the country where jury awards tend to be out of line with what's seen in the rest of the country, and in general, where the jurors favor plaintiffs over defendants. So those are the places where we're seeing what are called nuclear jury verdicts. So instead of claims that might elsewhere settle for hundreds of thousands of dollars, we're seeing them more recently settle for millions or even tens of millions of dollars. If you just quickly Google this, you'll see places like Cook County, Illinois, St. Louis, Missouri. The Atlanta region is pretty notorious for this. Philadelphia. These are places where they have litigation tourism. So plaintiffs come and file places in these jurisdictions for a specific reason because they're more confident they're going to have a favorable outcome when they do. Um, with certain insurance carriers, I can't speak for all of them. I mean, we have our carrier that we partner with, but in general, these areas really have to be subsidized by the rest of the country to some aspect. Insurance companies can only raise their rates so much every year, and because these jury verdicts are so far out of line in these specific pockets around the country, sort of everybody, the larger group has to pay for the questionable behavior in these jurisdictions.
Sure. Let me
Um,
ask you a question,
yeah.
Brian, because over the 35 years I've been practicing, we used to see CRNA premiums going down because there were so few cases against CRNAs. And now I hear you saying that's going up. My question is this: do you think it's because the whole country is learning now that CRNAs make a lot of money and they're seeing a pocket there. I don't know if we know that answer, but this has certainly changed during the years that I've been in this profession.
No, I think you're right. For a long time, premiums were steady. They didn't even pace with inflation. So we've done some studies showing how premiums compare from the mid 90s until now. And even when you factor in inflation, the premiums today still haven't outpaced it. So for a long period of time, premiums were stable. There's a lot of reasons why CRNAs are being brought into. That might be one of them. I don't think any plaintiff's attorney would admit that, but there's definitely where there used to be targets maybe on different professions, they're having a much wider viewpoint now, and they're targeting other professions they might have not in the past. I do want to say one thing. So I get asked a lot about autonomy, the increase in autonomy, and if that's a factor in premium increasing. And I always say not directly, at least not with our carrier. They have never raised premiums solely because the state opted out of supervision. So that's never been a factor. I mean, in the long run, there might be some kind of cause and effect there just because they're doing more cases, they're doing cases in different venues, things they might have not done in the past. But solely because they are granted autonomy, that has really no connection to an increase in premium.
Somebody put a question in the chat. Is there a way to match our malpractice coverage to the other professionals in the room to remove the target on our backs?
Um, Not oh, you meant like matched your coverage to. I mean, that's something I think maybe one of my prompted questions later gets into. That's an important factor when you're starting a new job somewhere is, I mean, I know it's probably not the easiest thing, it might be awkward, but you do want to try to make sure that you aren't the only person in the room with insurance and you aren't the only person in the room with high limits of insurance. Like I don't have an easy answer to how to do that, but it should definitely be a consideration. Is the target on the back thing. I mean, for example, in Florida, we see a lot of cases where our CRNAs are properly insured, other people in the room are not. And I mean, some cases where the anesthesia was clearly textbook, there was clearly a surgical mistake, but the only insurer in the room is the one backing the CRNA, so the target's on them. So that's an important consideration is to try to make sure you're not the only person in the room that's insured, or your at least your limits are in line with what everyone else has at the facility.
Yes, Brian, that's a great point. I hadn't even thought about that.
Yeah. One other, I think we need to address from a high level because I get asked this question all the time about the difference between occurrence versus claims made and the coverage and what does AANA offer?
Sure. So occurrence versus claims made, that has to do with the coverage trigger of the policy or what you have to do to ensure that you have coverage. So, um, in general, so I'll start with occurrence. That one's a lot easier to understand. An occurrence policy is triggered when an incident occurs during your policy period. So if I have coverage for, let's say, the whole year of 2026, if I file a claim 2 or 3 years down the road, it is eligible for coverage as long as my insurance carrier is still in business. It all it matters is when the policy term took place, that the incident happened during that term. Claims made throws a second wrench in there in that the incident has to take place during your policy, but you also have to make the claim during the policy period, which for medical malpractice in general, and even more so for CRNAs, claims often take some time to materialize, months, sometimes even years later. There is a way you can extend your claims made policy to have an extended reporting period. It's often called tail coverage, but that costs extra money, and that's not always something that if you get your policy through your facility, you might be responsible for paying that tail coverage. So I usually tell people occurrence coverage is very friendly to you as the consumer. 96% of our customers choose it. We offer occurrence to everybody without exception. Not all carriers do. Some carriers only offer claims made, some only offer occurrence in certain scenarios. It's very friendly to the customer, so that's our preference. It's just set it and forget it. As long as you have a good insurance company, you don't have to worry about having coverage. Claims made is a little bit different. Once your employment ends, that doesn't mean your policy considerations end. You need to make sure you have extra time after your policy expires during which to make claims.
Hey, Brian, I'm going to ask kind of a two-pronged question because I know that we get a lot of times questions about, why is A&A so much more expensive than X, Y, or Z? And I just always go back to some of the things you just said. I remember a few years ago, there was a carrier, I believe, down in Texas. I can't remember where it was, somewhere down there, that went out of business. And a lot of CRNAs were left kind of holding the bag. They might have done PEDS cases, and it could show up years from now on a claims and so forth. And they were left holding the bag, but A&A actually stepped in and helped those people out with some tail coverage there and so forth. So, can you just kind of address that elephant in the room? Why would we pay more for A&A coverage than we would, say, someone else, and so forth?
Sure. And that question comes up a lot, and there's really two different answers to that. The first one is the insurance company that we partner with, Medical Protective. They are a very strong company. They're owned by Berkshire Hathaway. They have the highest rating through insurance rating agencies, and they are solely a medical malpractice insurer. They've been around for over 125 years. They've got a very knowledgeable claims department. They're very knowledgeable about risks as well. I mean, the company you mentioned, I think you're talking about Oceanus. A lot of people will come dip their toes in the CRNA market because it's attractive. It's not, there's not a lot of options out there, and they dip their toes in and they try it out. And if it's not priced properly, it's not sustainable. I mean, insurance companies have a lot of money. They can afford to wait it out for 2 or 3 years and try to get some market share. But if it's not priced properly in the long run, they're either going to withdraw from the market or they're going to become financially insolvent, one or the other. MedPro doesn't have that concern. They've been around for a long time. They understand the risks, and their pricing shows it. I mean, some of our competitors now, I've done some research on my own, and their premiums are very close to what they're charging for RNs. And I think that tells you a lot about the knowledge that they have and the experience that they have. That's just not sustainable. But MedPro is very, very reliable. They're going to be there. Really, the other part of it is our staff. The insurance services staff has been serving CRNAs for almost 40 years. Our average staff tenure is about 15 years, and our customer service is top notch. Everybody on our staff knows what CRNAs do. They know what risks they face, the trends in the market. I hear them talking to CRNAs day in and day out, and nobody else. And I don't think any other insurance agency in our position can say that, and they don't have that expertise. I think there's something to be said for you get what you pay for to a certain extent, although I know that in some situations it just comes down to price. But we have a very strong carrier. We have a very good partnership with them. And like I said, our staff is top notch. They enjoy what they do, and there's no one more knowledgeable out there than the team we've got here at AA&A Insurance Services.
We have two really quick questions. I've not done a fantastic job of keeping these guys on time like I usually do, and usually the worst one is Jeremy, and he was tonight too. But anyway, the question in the chat is, do all surgeons not have to have insurance? You were talking about the target on the back and everything, and somebody asked the question, do not.
Yeah, we most frequently see that in Florida for some reason. I'm not completely familiar with every single state and the requirements, but oftentimes in Florida, we will see a CRNA being the only person in the room that has insurance when a claim is made, which makes it I mean, it's very difficult to get out of. It almost always goes to trial in that case. So I think it varies from state to state, but Florida is one particular state where the insurance requirements are very lax for other professions.
Interesting. And John, I think you had a question. Your hand was up.
No, I was just going to comment. I knew that Brian was going to touch a lot on malpractice insurance, and so I didn't bring that up, during my time. But obviously, malpractice and how that's set up in your contract. If you are a contractor and you're responsible for providing it, sometimes contractors, there's a delta between what you get paid and what you take home, and the expenses are often in between, of course. And so you want to minimize expenses, and sometimes a inexpensive policy can make your profits more, so your take home is higher. But this is obviously not one of those things to cheapen up, and especially when it comes to tail insurance, a claims policy. Brian would have more details on the actual nuances, but a claims policy is cheaper because it doesn't have all the benefits that an occurrence policy does have. So so understand, of course, which type of policy you are purchasing. If you're purchasing a policy, and like what Brian said, sometimes you get what you pay for, and I think this is one of those instances. He laid out some good cases for it. If you
Yeah.
are working with somebody now and you're thinking about transitioning to a 1099, your current contract says you will have malpractice insurance as one of your benefits. It's really important, of course, during that due diligence and that clarification phase that you understand, well, what's provided? Is it an occurrence policy? Is it a claims policy? And if it's a claims policy, who buys tail? And of course, all that should be very, very clearly documented in the contract. And to Jeremy's point earlier, under what circumstances? If they lose the contract, what happens? If you can continue the policy, if you're working at multiple different facilities, does that policy lay over on all of them? If you have a part-time W-2 position or a contracted position that's providing you insurance with that position, does that insurance cover you on your other 1099 opportunities? And so all those things are super important when it comes to malpractice insurance, and how that's documented in your 1099 contract or your W-2 contract, if that's what you're currently under.
Well,
Yeah, those are great points. Great points for sure. Well, Sharon, we have reached that bewitching hour. I'm going to let you wrap here. I usually do the wrap, but I'm going to let you wrap.
well, my goodness, I feel privileged. So I want to thank all of you panelists for coming and sharing your expertise into the CRNA 1099 landscape. Um, all the things that we have just whet your appetite with everything tonight. And I just want to let you know that the AANA recognized the void that where there was not a lot of 1099 education available for people to learn how to do this. So we partnered with the AANA. Jeremy and I teach a whole course. It's called the 1099 CRNA Institute. It's housed with the AANA because they wanted to become responsive to the members, and seeing that there were being more 1099 CRNAs in the market, you can go to the website and look at it. It was designed to help you understand the business, the financial, the legal, operational aspects. Just it is in depth of just a few of the things that you heard about tonight. Um, just go online and take a look. We appreciate you being here tonight. Sorry, I took 3 extra minutes of your time here, but we appreciate you joining us. This will be available for later as it was recorded. And so, Jeremy, I'll let you have the last word and you enjoy it.
Wow, I appreciate that. Yes, well, yes, everyone who is on the meeting tonight and everyone who signed up for it will get a copy of this. And I just want to say a special thank you to each one of you who are on here tonight with us. I mean, Nick, really appreciate you. You did a great job. You're not getting out of this anymore. We're going to be calling on you, man. I know you're a
Absolutely.
busy guy. You got a lot going on, but very, very thankful for you. John, same for you. I've known John for years now. He always does a great job. He's a very busy guy. He's always traveling, doing stuff. And thank you for your time as well. Brian, ANA made you be here. I'm just kidding. Brian loves what he does, man. He eats, sleeps, lives, and breathes this stuff, and insurance is his jam. Whereas for most of us, that is not our jam. We're glad Brian's around. Just want to thank you for your time. As always, you did a wonderful job making insurance not as dry as most of us think it is. Okay. And then last but not least, Tracy gives so much back to the CRNA community. I mean, he always has, and kind of like Sharon, both of them have chosen to dedicate their careers not only to themselves but to the CRNA community. As Sharon's a past president of ANA, and Tracy's president-elect of ANA, and that takes a lot of time and effort. And Tracy, anytime you call him and ask him to do anything, he's always a yes man. We truly appreciate that, because his time is extremely valuable with running a company and doing all the stuff that he does. So we want to thank him for being here tonight as well. So great job, everybody. Thank you, everybody who attended, and we hope you have a great night.